Hello people, in this video let us look at coronary heart disease under community medicine, that is PSM, preventive and social medicine, epidemiology of chronic non-communicable diseases. These diseases don't go from person to person, right? So they are non-communicable disease and conditions like cancer, etc. Here we are looking at coronary heart disease, or it's also called as ischemic heart disease. We are looking at its epidemiology, right? So what will you look at in epidemiology? Disease burden, preventive measures, national schemes for all this, etc. So let's get started first at looking at this image here. Coronary heart disease. So this is the normal artery. What do you see in the normal artery? Normal artery has red blood cells inside it, so this is perfectly fine. In the abnormal one, there's a plaque here. So there is narrowing of the artery, right? So that could lead to a coronary heart disease. So there is not enough blood supply, right? So what will happen? This is also called as ischemic heart disease, IHD. So let's look at this disease. So basically it's a non-communicable disease you got. So impairment of the heart function because of inadequate blood flow to the heart. So what is happening here? There's inadequate blood flow to the heart. So there is impairment of the heart function compared to its needs. So it's a comparative thing. So it may be normal for some people, but based on the needs, it may be inadequate. Okay. So this is caused by what? Why is this inadequate blood flow to the heart? Because of obstructive changes in the coronary circulation, which you just now saw, because of atheromatous plaque, etc. So this is the cause. Basic cause is obstructive change in the coronary circulation. So this is called as modern epidemic by WHO, because 25% or to 30% of the deaths in the world are because of coronary heart disease. How will coronary heart disease manifest itself? So it will manifest itself as, mainly you can remember, angina, right, discomfort, pain, etc. Basically myocardial infarction, irregularities of the heart, you can say some ECG changes, etc. Cardiac failure, sudden death. So mainly you remember what? Myocardial infarction, angina and myocardial infarction. Guys, there's a lot of information in the textbook on this, okay? So we will just go through few things. Don't look at everything. See, when it comes to measuring the burden of the disease, we told you, right, 20 to 30% of deaths in the world is because of CHD, that is coronary heart disease. There is something here. They're talking about the age-specific death rate, prevalence rate, incidence rate, etc. We're not going into the too many details of this, but just remember some specific things, okay? There is something called as MONICA. What is MONICA? Multinational Monitoring of Trends and Determinants in Cardiovascular Diseases. So WHO has completed this project to elucidate this issue. Which issue? There is actually a decline in the mortality now, probably because people are controlling their blood pressure better, right? So they are in better control of hypertension, and also because of changes in lifestyle, etc. Now there is a decrease, looks like, okay? So to understand this changing trends in this coronary heart disease, WHO has completed a project known as MONICA. What is MONICA? Multinational. What is MONICA? Multinational Monitoring of Trends and Determinants in Cardiovascular Diseases. How did they get all this? CA is cardiovascular, okay. N is I, okay. What is N? Monitoring. Oh, okay. Just we'll write it again then. Let's try to understand this in a better color. MONICA, Mon, I, CA, okay. So MON is monitoring, multinational monitoring of trends, okay, and determinants in cardiovascular diseases. I think this is the way it is, but anyways, if you have a better logic to it, why it is MONICA. So what did they do to elucidate this issue? Which issue? Changing trends in cardiovascular disease. So 41 centers in 26 countries were participating in this project. So it is going to end in 1994. So it has ended, right? Yeah. So what did they find out? So they found that in developed countries, it is still a public health problem, but there is a decline. But for men under 65, it is the most frequent single cause of death. Okay, for men. Got it, right? So international variations they are saying, where is it more looks like? It's more in Southeast Asian region. That is our region only, right? Southeast Asian region only it is more. No, it is more in Europe also. So more in Europe and SEER countries, because Europe they are saying the percent of total CHD deaths is like 30% and SEER is 25%. So if you consider Europe countries to be developed, so coronary heart disease is more, but in Americas and all it is lesser than us, even our countries. Shall we continue, people? So where are we? We finished international variations. Now let us see in India how the situation is. Okay. Coronary heart disease in India. So this is what you will read in epidemiology, right? Let's finish off this, then we'll go to a little more better things, okay? In India, how is it? In India, in urban areas, this is a very big cause of death, looks like, and the prevalence is increasing, okay? So that's what you can remember for India. So you got the gist of it, guys. Measuring the burden of disease, epidemicity, international variation, India, everything we have. Risk factors, guys, let us look at the risk factors now. So you have non-modifiable and modifiable risk factors. So what people can't change? They can't change their age. They can't change their gender, right? Or sex. You cannot change family history, genetics. Personality you can change, but they have put under non-modifiable and they put question mark. What are the modifiable things that you can modify in your life? Cigarette smoking, stress, sedentary habits, obesity, diabetes. Can you actually modify diabetes? You can just control it, I think. Cholesterol, high blood pressure. Okay, so all these are modifiable. Modifiable, what have they put? Come on, name the modifiable ones. Modifiable you have. You can modify your smoking, yes. Can you modify your blood pressure, high blood pressure? Possibly. Can you modify your stress? Possibly. Can you modify your diabetes? Looks like you can. Can you modify, what else can you modify? Can you modify your obesity, sedentary habits, etc.? You should try. Cholesterol also you should modify, okay? So risk factors, they are saying 51 to 60 years of age, males are more affected. Smokers, people who have hypertension, high serum cholesterol, other things like diabetes, physical activity being low, hormones, type A personality. This is what they said, no, personality is not modifiable. Interesting. Alcohol, oral contraceptives and other conditions. Let's remove miscellaneous. Okay, so this much. So you got the risk factors for coronary heart disease. You have to divide it as modifiable and non-modifiable. Okay. So let's move on. Some graphs they've shown here. Let us look at these graphs. What do you think this graph is? So this is the systolic blood pressure and this is the probability of myocardial infarction. So if your blood pressure is high, your probability of myocardial infarction is also high. Okay. What else is there in? This is hard to understand. This is Japan, it seems, and this is Finland, East Finland. These people's cholesterol level is somewhere here, and Japanese people's cholesterol level is between 100 and 200. So it's less. Correct? So what is this frequency? mg per deciliter. Cultural differences in serum cholesterol levels. The only thing we can tell you is Finland will have high number of CHDs. These people will have high coronary heart disease. Why? Because they have high cholesterol. That's what we can say. What do you say? Finland, the highest incidence of CHD. Okay. So what are they showing here? Some threshold level of cholesterol. So the certain level beyond which there is an association. So we finished blood pressure here. We finished serum cholesterol here. Last graph, let's see. Same thing, serum cholesterol is increasing. Incidence is also increasing. Okay. I think you just draw this one, okay. As systolic blood pressure increases, the chance of CHD increases, and as serum cholesterol increases, chance of CHD increases. That's it. These two graphs are enough, okay. Let's move on. Prevention. Now that you know the risk factors, how will you prevent? You have some population strategy, and then you have high risk strategy. They are mentioning two strategies here. So what will you say here? Mainly in population strategy for prevention for whole population and primordial prevention in whole population. Prevention in whole population and primordial prevention. Shouldn't primordial prevention be put before this prevention? Okay, primordial prevention means what? You will try to remove the risk factor itself, right? So here for risk factor intervention trial, so it just got complicated. You will have to learn all these studies. This is Framingham study. Okay, it is a prospective cohort study to understand the risk factors of coronary heart disease. Framingham is actually a place in Massachusetts in USA. We have to look at that in detail. Then Stanford 3-committee study. Then MRFIT. This is multiple risk factor intervention trial. Then you have this North Karelia project in Finland. What is this Karelia? Then you have lipid research clinic study, etc. Guys, so remember in primordial prevention, you'll have to write the names of all these studies. Framingham study, you'll have to explain much in detail. We will come to this, okay? In a separate video, you can look at Framingham study and write about it. Basically, you saw that in, what did they do here? In this place in US, that is Massachusetts, Framingham, a town of Framingham, they took some 4,469 people in 1948 and they were followed for a 20-year period. Every 2 years they were having checkup, and they found how many people developed coronary heart disease, and they found that smoking was a strong cause of death in these people. So smoking was strongly associated. Also serum cholesterol was associated, and male sex also was associated with this. Okay. So they found that this study was very, very good. When was it? 1948. It is a prototype for similar studies. It's a prospective cohort study because they followed up them for 20 years. They also found that men gain most weight when they are from 30 to 35, like that. Women gain post-menopausal, at menopausal age they gain. Then coming to prevention and whole population, let us look at this. Here you have something called as a prudent diet, dietary changes. Then obviously you will have to give up smoking and regulate blood pressure, physical activity you should have, etc. Right? So guys, in dietary changes, prudent diet is important. Look at this. Guys, let us look at prudent diet. This prudent diet was given by whom? By WHO, the expert committees of WHO. Basically, prudent means well judged, wise kind of a thing, right? So they are saying reduce salt intake, okay, and avoid taking high alcohol. Okay, fine. Looks possible. Okay, then let's come to the technicalities of it, okay? See if you can achieve all these now. Dietary fat should be limited to approximately 15 to 30% of the total daily intake. So, fat should be less, okay? Limited to. So, it should be less. Fat should be limited to 15 to 30% of your total dietary intake. So, it should be less. Saturated fat should contribute no more than 10% of the total energy intake. So, saturated fat also should be less, okay? Then, so 10% less than that should be saturated. Remaining can be unsaturated vegetable oils. Of this 30% in your complete food, 30% will be fat. In that 30%, 10% only should be saturated fat. The remaining 90% of that 30% will be unsaturated vegetable oils. You understood? Or it just became too much? So you have here 30% you can take fat. In that 10% can be saturated fat. Remaining have to be vegetable oil, unsaturated. Got it? Very good. Excessive consumption of refined carbohydrate should be avoided. Some of the carbohydrate rich in fiber should be taken. So take carbohydrate which is rich in natural fiber that they like. Okay. Refined carbohydrates don't take. What is that refined carbohydrate? Yes. Okay. Whatever is white, right? White flour, white bread, white rice, sodas, snacks, pastries, sodas, snacks, all these will be refined carbohydrate. What is natural carbohydrate? Rich in natural fiber. Maybe it's all these fruits, vegetables, etc. Okay, rich source in energy such as alcohol should be restricted. Salt intake should be reduced to an average of not more than 5 grams per day. This you know, no? DASH regimen also it's there. Salt intake also should be less than how much? 5 grams per day. Okay. All these specific things you have to write. Prudent diet means. It's not just saying eat less salt and less alcohol. Salt how much? Less than 5 grams per day. Okay. In India we take 15 grams per day it seems. Probably I take more than that. Okay. Protein should account for approximately 10 to 15% of the daily intake. 10 to 15% protein. So did you get it? Whatever you're eating, 30%, 15 to 30% only, maximum 30% you can eat fat. 10 to 15% should be protein. Remaining can be carbohydrates, look like. Okay, in that also you should have fiber-rich natural carbohydrates. Fats, 10% should be saturated fat. Remaining should be unsaturated. Protein, did they say anything? No. Junk foods you should not eat. That and all you will write. Not difficult to write. So did you get prudent diet now? Now is it completely clear? You cannot just write some things. You have to write specifically what they are saying. Lastly, they are saying that there will be special needs for growth, pregnancy, lactation, physical activity and medical disorders. There will be separate special needs. You'll have to address that. It's not that one for everything, right? So we are done with prudent diet by expert committees of WHO. What are they saying here? You should have reduced salt intake and avoid alcohol. Okay. Alcohol also you should avoid. Okay. This is suggested by whom? WHO expert committee. Prudent means well judged. Basically, fat should be less than 15 to 30%. Saturated fats should be less than 10% of the total energy intake. If I'm not wrong, this is the fat intake. In that fat intake, 10% should be saturated, right? Guys, if just check that once, okay? Then you should take carbohydrate, which is rich in natural fiber. Alcohol, you should restrict. Salt intake less than 5 grams per day. Protein should be around 10 to 15% of your daily intake. Junk foods you should avoid, okay? Special needs are there for growth, lactation, pregnancy, physical activity, medical disorders, etc. So this is about prudent diet, okay? So in prevention of coronary heart disease, in population strategy, prevention in whole population, we are suggesting this prudent diet, okay? This is where it comes under, but you can prevent a lot of other things also. Just remember people, HDL, that is high density lipoprotein should be more. It should become more than 40. Low density lipoproteins should be less. Okay, you should bring down your LDL. You should increase your HDL. And your cholesterol also you should bring down. Serum cholesterol you should bring down. So cholesterol divided by HDL. HDL should be more, right? So that time this fraction will become less. So it should be less than 3.5. Okay. See, cholesterol should be less. HDL should be more. So what will happen? This ratio actually has to be less than 3.5 they are saying. So remember, HDL more, LDL less, cholesterol divided by HDL less than 3.5. Some targets they are there. So we are done with prudent diet. Okay, so we are done with dietary changes. Now let us look at smoking. So they have to what? Give up smoking, right? What else will you say? Smoking is a strong association, they said, right? So smoke-free society, all this no smoke zones and all that, you can write that for a population strategy. Blood pressure. Again, here they're talking about prudent diet. The DASH regimen, you know, right? Dietary approaches to stop hypertension. All that you can write, and same thing. Salt should be less than 5 grams per day. Okay. And there are a lot of drugs to stop hypertension also. Then coming to physical activity, you should tell them to do moderate exercise. Right? That's it. Throughout their lives. Primordial prevention, we saw all the risk factors. Then coming to high risk strategy. For high risk population, what will you do to prevent this coronary heart disease? Guys, we are back on the prevention of coronary heart disease. We're looking at high risk strategy. You will identify the risk. See this. You will identify the risk. Individuals at special risk, you will see who smoke, who are obese, people who are using oral contraceptive pills. These are the people who are high risk. So you will identify them. So identify people who smoke. Is it becoming too much, guys? Yes, here it became a little more specific again. Oslo Diet Smoking Intervention Study, Lipid Research Clinic Study. All these you have to mention here. These are high risk intervention studies, okay? Oslo. Is there a W here or there's no W? Oslo and Lipid Research Clinics Studies, okay? So it is feasible to reduce coronary heart disease risk factors, okay? So this is high risk intervention studies, remember, okay? Guys, so we finished kind of a primordial prevention and prevention. Now let us look at secondary prevention. Secondary prevention means that person has got coronary heart disease. What secondary prevention will you do? You will make sure that he will not get it again, right? You will not get a subsequent coronary attack, or he will not go into sudden death. So this is what you want to protect the person from. That is secondary prevention. That means the disease has already come. So you want to early diagnose and treat, basically, right? So what will you give here? Anticoagulants, lipid lowering agents like clofibrate, anti-thrombotic agents like aspirin. So this is a blood thinner kind of a thing, right? Beta blockers. So all this you should mention. These all will protect the person from subsequent coronary attack or sudden death. Okay. Most promising is beta blocker. Okay. Guys, we are done with the prevention of coronary heart disease. Still, what is there? Prudent diet we finished. Then revascularization procedures for these people. What treatment we speak of? There is revascularization procedures, CABG and PTCA. What is CABG? Coronary artery bypass grafting. So you will revascularize so that who have angina pectoris, right? That means they have discomfort, pain. For those people, they are doing revascularization. There is PTCA. What is percutaneous transluminal coronary angioplasty? Wherever C is there, CA is there. Remember, it's coronary and artery coronary angioplasty. The CA is coming at the end. Here, CA is coming in the beginning. Coronary artery bypass grafting. Percutaneous transluminal coronary angioplasty. Okay, so there is something more about this. You can read all this. Then risk factor intervention trials. We told you Framingham study. It's one of the earliest studies. Then you have these three for what risk factor identification and all that. Then these two are for high risk intervention studies. Each of these have been explained in the textbook. Secondary prevention you saw. Then in India, what is the national program for non-communicable diseases? Guys, focus here, guys. We're at the end of this. Okay, don't worry at all. So here we have what national program for prevention and control of these NCDs, that is non-communicable diseases, like what? Cancer, diabetes, cardiovascular diseases, and stroke. So you can just mention this national program for prevention and control of cancer, diabetes, cardiovascular diseases, and stroke. So here what and all will be there? You'll have sub-centers, community health centers, district hospitals, etc., where they will screen people. Health promotion they'll screen people, and then they'll refer them to higher levels so that they can get diagnosed and treated. Okay. What else you should know here? So now it is there in the 35 states and almost 496 districts, etc. That's it, guys. We are done with this very important topic in community medicine, that is coronary heart disease. So you have looked at everything. What did you look at? What exactly it is? How will it manifest? The burden of the disease, this MONICA thing, multinational monitoring of trends and determinants in cardiovascular disease, right? So they ended it in 1994, and then they found out why there is a decline in the death rates because of coronary heart disease. It is actually 25 to 30% of deaths is because of coronary heart disease. There's a decline. Why they tried to find out? It is still the most frequent single cause of death among men under 60, but it has declined. Okay. Then international variations. It's more these coronary heart disease problems are more in Europe and Southeast Asian region. In India, nowadays the prevalence has increased in urban areas. Risk factors, we saw non-modifiable and modifiable. So basically you should remember that smoking is a strong association. High blood pressure, elevated serum cholesterol, that is also very important. Then diabetes, etc. Males are affected more, 51 to 60 years. Type A personality, people who take alcohol, oral contraceptives also not good. Long-term use, okay. Then people don't have physical activity, obese. So as the systolic blood pressure increases, the incidence of myocardial infarction increases. As the incidence of serum cholesterol is elevated, the amount of coronary heart disease is more. Okay. So we're taking a recap, guys. Focus. So what is the prevention? You have the primordial prevention. You saw so many studies. You can remove the risk factors itself. Prevention in whole population. You have this prudent diet where you reduce the fat intake, etc. Smoking you have to reduce. Blood pressure you have to reduce. Lot of drugs are there to reduce blood pressure. Also they talked about what? About blood pressure. Salt intake should be less. Remember all that you should write. Then physical activity, moderate physical activity, full life you should have. Primordial prevention in whole population we saw. All these studies you have to mention. Framingham study, Stanford 3 committee study, North Karelia project in Finland, MRFIT, Mr. Fit, multiple risk factor intervention trial. Let's remember it like this. Mr. Fit. RF is risk factor. So this is also an intervention trial. Okay. Then high risk strategies, you'll identify people who smoke, who are obese, who have diabetes mellitus, who use oral contraceptive pills, and then you give them specific advice to give up smoking, etc. High risk intervention studies, you have the Oslo diet or a diet / smoking intervention study. You have the lipid research clinic study. If you can remember all this, great. Secondary prevention, we told you, you have to make sure they'll not go into a second coronary heart attack, and sudden death should not happen. So you'll give them what and all? Beta blockers, blood thinners like aspirin, etc. Lipid lowering agents like clofibrate. Clofibrate will do what? It will lower the lipid levels. Very good. This is all secondary prevention. Then we looked at in detail about the prudent diet, right? You should increase HDL, lower LDL and cholesterol. Prudent diet means fat should be limited to 50 to 30%, saturated fats not more than 10% of that. Then you should take carbohydrate rich in natural fiber. You should restrict alcohol. Salt should be less than 5 grams per day. Protein should be 10 to 15%. Don't eat junk, etc. Special needs are there for pregnancy, lactation, etc., puberty, etc. Revascularization procedures as a treatment. CABG, that is coronary artery bypass, grafting. PTCA, the percutaneous transluminal coronary angioplasty. Percutaneous transluminal, all those words you should remember. All these are the intervention trials. You have to mention these. Coming to Framingham study, this was in America, in the Massachusetts state, in Framingham town. They got 4,669 people and followed them up for 20 years. Every 2 years, they studied them for the development of coronary heart disease, and they saw that smoking was most strongly associated. Even serum increased cholesterol levels, and also male sex. All these had effect on association. It had on what, guys? Coronary heart disease focus. It was a prospective cohort study. It was actually so good that it became a prototype for similar studies. Okay, Framingham, remember. Then they also found that men gain weight from 30 to 35, women gain from 45 to 40, 45 to 49 when it is menopausal age. Secondary prevention trials. Yeah, we already told you all the drugs that you prevent. Then NPCDCS, that is National Program for Control of Cancer, Diabetes, Cardiovascular Diseases and Stroke. So we told you there are 3 levels here: sub-center, community health center, district hospital. Sub-center or any other levels also will screen the people and refer them for diagnosis and treatment to a higher level. Okay, that's all for now, guys, in this huge video on coronary heart disease. Bye bye.